Hello and welcome back to my injury presentations. This presentation is about medial epicondylagia, or golfer's elbow. My name is Aaron Lang, and I'm producing this video for Dr. Michelle Thornton-Adler and her individual and dual sports class of the fall of 2018. The process this video will undergo is to give a background on the patient whose name and injury I have made up, as well as the anatomical background of the injury and the origin of the injury in the sport that this person plays. I will then perform a SOAP note, which stands for Subjective Objective Assessment and Plan, with subjective being more of a history portion of an injury evaluation where the patient reports sensations or feelings. And although this information is not always perfectly reliable, since everyone has differing pain tolerances, it is very important to listen and ask good questions to the patient. The objective portion of the note is where I will measure or observe different values and details, such as range of motion and strength. I'll put this together to come up with an assessment or diagnosis, which is the state of the injury, and as well as a differential diagnosis about other potential injuries. Then I'll formulate a plan, in this case a rehab protocol. Our patient is a Mr. Mort, who is a middle-aged man who injured his forearm playing a badminton tournament for a fundraiser over the weekend. He is an Olympic lifter and is otherwise healthy and fit, and he wants to get back to Olympic lifting as soon as possible so he can keep knocking out those PRs and proving that he is a full-fledged man. When we look at the anatomy of medial epicondylagia, or golfer's elbow, you have the medial epicondyle of the humerus here, and the forearm here, and the wrist here. The medial epicondylagia refers to alagia, or pain, of the epicondyle of the humerus on the medial aspect of the arm. This pain comes about because of inflammation or stress put on the medial epicondyle, which is the origin of the flexor bundle of the wrist. As you can see here, these flexor muscles. So these muscles become tightened, which pulls on their origin, causing pain and stress to the medial epicondyle. So how does medial epicondylagia occur in badminton? Well, medial epicondylagia is, as I said, characterized by pain and swelling of the flexor bundle of the wrist, which originate off the medial epicondyle of the humerus. This stress and swelling can be caused by excess, usually compound, strain on the muscles, meaning it's occurring over time, on the wrist flexor bundle. This strain is caused by repetitive contraction of the wrist flexors, such as when you're snapping a badminton racket, when you're killing the birdie, or in powerlifting during the catch of the clean, or at other positions during the powerlifting movements. So when we move into the subjective portion of our SOAP note here, we find that our patient is a middle-aged man reporting sharp 7 out of 10 pain on the inside of his elbow while he plays badminton. He reports no single instance of pain increasing, but pain did increase dramatically over the weekend. He cannot remember what movements hurt the most. The patient also notes that after the powerlifting sessions, usually, he has experienced a little irritation for several months, but hasn't worried about it until this weekend. In the objective portion of the note, we find some swelling around the medial elbow. There's no deformity, thankfully. There's no discoloration. The patient is tender to palpation over the medial epicondyle and the wrist flexor bundle. With his active range of motion, he's within normal limits with all planes, but has 3 out of 10 pain with the wrist flexion as he contracts that wrist flexor bundle. With passive range of motion, he's within normal limits in all planes, but he has a 2 out of 10 pain with wrist extension as I pull him back and stretch those wrist flexors. Manual muscle testing reveals decreased strength with a little bit of pain in wrist flexion, but otherwise normal. I do a valgus stress test because I'm worried about the ulnar collateral ligament, but there's no sign of laxity. His neurological symptoms are within normal limits. He has no radiating pain or numbness or tingling, which is good because I also I'm looking at the ulnar nerve to ensure that there's no ulnar neuropathy. With that known, we can now get into our assessment, which is that our patient, Mr. Mort, has mild medial epicondylagia and some swelling. As a differential diagnosis, we have ulnar nerve neuropathy and ulnar collateral injury. My plan is to begin home and clinic treatment plan immediately. The patient will attend 3 therapy sessions per week. The patient will see a radiologist for imaging if pain persists past 1 month, or if neurological symptoms start to develop, such as numbness or tingling. The patient, if he's compliant, will begin anti-inflammatory diet to reduce his swelling, as well as to promote the recovery and healing process. Additionally, this diet would help him in his athletic endeavors. The patient will use the RICE method, with RICE being an acronym for Rest, Ice, Compress, and Elevate. In this case, our patient will stop any activity that causes pain, especially powerlifting and the occasional badminton. The patient will use ice for pain control and a compression sleeve on the elbow to increase blood flow to the area and to remove the swelling. Finally, the patient will elevate the elbow above the heart when able to do so, but it's not really practical, so I don't emphasize this. The patient will begin stretching immediately to loosen up those muscles. He'll perform stretches twice per day, holding each stretch for 30 seconds, 3 times per session. So the patient will stretch in the clinic as one of his twice-a-day stretches, and stretch outside the clinic on his therapy days at least once. The patient will also begin strengthening of the wrist as soon as pain subsides, to prevent further injury and to correct any muscular imbalances that are present in the wrist. The patient will perform strengthening exercises every day, performing 3 sets of 10 repetitions of each exercise. Once again, when the patient is in the therapy session at the clinic, that strengthening exercise session will count as his daily session. As promised, the anti-inflammatory diet was also discussed. I will have the patient eat more whole grain foods, more vegetables, more turmeric, more garlic and beans, more fish, and nuts. And as this is unlikely to happen with the patient, I will also encourage him to eat less highly processed foods, highly processed sugars such as candy, sugar in your coffee, and even some sweetened fruit juices are really high in sugar. I will also have the patient cut alcohol, if they are willing, as well as salt. The stretches that I'll have the patient perform include, on the left here you can see a passive wrist extension and flexion, beginning with a passive wrist extension here in a supinated position. The arm can be rotated over into pronation to place another angle of stretch on the wrist flexor bundle. I will also have the patient perform wrist flexion stretches to stretch the muscles of the extensor bundles, just to maintain a healthy balance, with supination and of course with pronation here. Other stretches include the very simple and easy to do prayer stretch. I'll mute myself there. As you can see here, I'm keeping the palms together. Also reverse prayer stretch, where you put the back of the hands together, and pull down. Hold these stretches for 30 seconds, not as the few seconds I've illustrated here. And on the floor or on a table, you can perform, in this case, a pronated wrist extension stretch for those wrist flexors. And for healthy balance, of course, perform the wrist flexion stretch there. Here it is again, another variant of the wrist extension stretch, and another variant of the wrist extension, stretch. So with the stretching done, we can move on into the strengthening. The first exercise of which would be the 5-finger death push. The 5-finger death push is performed by opening the fingers and pushing the hand down into the floor while resisting by flexing the fingers and the muscles of the wrist. The hand on top can add extra pressure to increase the intensity. Return on the right, we have wrist flexion and extension. And to mute myself again there, you have wrist flexion, extension. I demonstrate with my leg that you could use a table or a bench or support your arm with the other hand. And then I go into sword fighting and radial deviation in this case. And any equipment might be used, such as a dumbbell or water bottle, or in this case a curtain rod or a light-weighted bar would be especially good. I call this one the back scratcher. It's another ulnar deviation variant. Finally, there's a pronation supination that is very good with this. We have more strengthening exercises. This one on the left here is a dynamic movement which should not be performed until the athlete has been nearly cleared for return to play and has no more pain in his elbow. This exercise is a dynamic and rapid concentric with a controlled stop to place an eccentric load onto the muscle. On the right, we have a badminton specific exercise here. And although our patient is not a badminton player, this is useful for those who are rehabbing badminton athletes. In this case, the swings, and here the forehand, is performed with this weighted rod, as well as an overhand either kill or hit. These exercises can be incorporated into the rehab program as directed in the plan and should help the patient achieve normal function. This is all I have for this presentation. I hope it's been helpful, enjoyable, and not too boring. Feel free to check out these amazing resources for more information about medial epicondylagia. Thank you. One last thing I must add is Merry Christmas.